my goal today, we're going to talk about targeting the androgen receptor in castration-resistant prostate cancer. And these are my disclosures. Where I want to go with this talk is I'm not going to talk too much about drugs. Neil gave a wonderful presentation about all the newer agents that have been approved, specifically since 2010. I think most of you in the room have heard this, have read about all the new agents. But I really want to stress the fact that I think if you're interested in managing prostate cancer, especially as we move from this volume to value-based medicine, as many of you know, we have been preaching for many, many years that we want the urologist to be involved in the total continuum of care. And specifically, especially as we become less and less invasive. My father was the first urology resident at the Leahy Clinic. I've been around this all my life, and I love David's video that he just shown. But I think as we are progressing to, even though we still are a surgical subspecialty, as we become less and less procedure-driven, and as we get more and more of these great agents and the challenge of treating metastatic castration-resistant prostate cancer, I think it's imperative that we start to understand the molecular mechanisms and the drivers behind what's driving this disease. So we all know it's the Huggins and Hodges in 41, as the video just showed. Basically, they proved that prostate cancer is an endocrine-driven disease. And the mainstay of therapy, once patients progress with prostate cancer, has always been knocking out testosterone. Tom Keene showed this slide earlier. We know that there's basically three sources. Obviously, the majority of testosterone production that comes out of the testicle. You get about 3 or 4% that has this paracrine production from the adrenal gland. And now we know that you get that through mutational changes. Sometimes that is actually pressure treatment driven, like Dr. Pinthas talked about, that you get this autocrine production, where the tumors themselves are producing their own testosterone. And when I talk to my patients about what that means, the analogy that I use is that it would be like a car making its own gasoline. It'd be great if you had that type of car. It's not so good if you have that type of tumor. Again, I stole this from Crawford, or maybe I might have stole it from Neil, who stole it from Crawford. So the bottom line is that, fortunately for all of them. Okay, so this actually is in a graphical form, not as cool as the video that you saw. It's basically the history of how androgen deprivation, how we've been successful in lowering serum testosterone. And when you look at what we've done in the past, especially for those of us that trained in the 90s, obviously surgical castration, before 1990, surgical castration was always the mainstay. But again, a lot of us used diethylstilbestrol or DES, which was a great drug. The problem with DES at the 5 milligram dosing, it did a wonderful job in controlling prostate cancer, but it was also very associated with thromboembolic events, and it also turned out to be teratogenic. Then we've used anti-androgen. David published some really landmark papers on complete androgen blockade, and then as well as we have androgen synthesis inhibitors. But again, the mainstay, especially as patients advance, has always been knocking down the testosterone to less than 50, which has historically been the definition. Now, we can have a whole nother discussion whether it should be less than 33, less than 20. I think most of us believe that lower the better. But ADT still is the cornerstone. But at the same time, it is not without risk. It's not without complications. And as you know, a lot of times it's the urologist. We start ADT, especially in the setting of a biochemical recurrence for those patients who have been definitively treated. And again, it's got some major problems, and I think all of us, we owe it to our patients to really discuss this with them. And again, this is becoming more and more people are becoming more and more aware, and again, as we move into this post-macro world of alternative payment models, bundled payments, MIPS, one of the things that we're going to need to be tracking is quality of life. So I think ultimately, this is just sort of a sidebar, I think we need to be, again, especially in the area of biochemical recurrence, we need to do a little bit better job. We need to be more judicious in our use of ADT. But again, we all know what the complications are: hot flashes, anemia, sexual dysfunction, neurocognitive dysfunction, which can be really bothersome, and I think we're becoming more and more aware of that. Osteoporosis, and I think Lenny Gamella is going to talk about that tomorrow. And obviously this pseudometabolic syndrome, which includes obesity, insulin resistance, dyslipidemia, and hypertension. We know that these patients, once we get them on ADT, they will progress. Not all of them, but they will progress. And when you look at the NCCN with this concept of what we call castration-resistant prostate cancer, we talked about earlier today why that nomenclature has changed. And I'm going to give you some of the molecular reasons why we've gone from this concept of hormone refractory, androgen insensitive to castration-resistant prostate cancer. So the first area is this area called M0, where by definition, the definition of castration-resistant prostate cancer, you got to have a diagnosis of prostate cancer, you have to be on LHRH therapy, your testosterone levels need to be in the castration range, which right now by definition is less than 50, and you have to have a rise in your PSA. And again, as you know, most clinical trials define that as elevations 25 to 50% greater than the prior, with between 1 to 2 weeks of it being drawn. If you then study them radiographically, we know that about a third of these people who you think are non-metastatic, usually based upon their symptoms, in fact are symptomatic, are metastatic. So it really is incumbent upon the urologist for us to be early identifying these patients. But we know that there is this subset of patients who really do not have radiographic spread based upon bone scan and CT. Now, I think many of us believe, especially with some of the newer advanced imagings that are coming out, and I think Dan's going to touch on that soon, is that this area, this niche of patients will probably become smaller and smaller. But suffice it to say, right now, if you truly are in this M0 CRPC category, your treatment options are clinical trial or observation. None of these cool drugs that we have are currently approved for the M0 patient. You have to have metastatic disease. And the older therapies, including the first generation anti-androgens, don't have a survival benefit. But then as you get into the M1 disease space, which again is this CRPC, but they do have radiographic mets, then the whole world opens to us in terms of all these new therapeutics. These are kind of the key clinical trials that have been put forth since 2004. These are the positive trials. But again, I think when you sort of look at this, all these different agents all are different mechanistically. And again, this is sort of a summary slide that many of you have seen, looking at the survival benefit of all these particular agents. However, and this is where the meat of the talk's going to come, many of these agents, what still remains central to the progression of these patients is this androgen receptor. And I will say that if you would have told me 10 years ago, Concepcion, if you want to manage advanced prostate cancer, you need to be fully aware of the androgen receptor and where it's located and those types of things, I would have told you you're out of your mind. I don't think you can begin to understand or begin to treat and know about these drugs until you really have a good working knowledge and definition of the AR. So suffice it to say is that it's found on chromosome 11, and the androgen receptor actually has four major domains. It has the N-terminal, it has the DNA binding area, it has the ligand binding domain, and then there's actually a hinge region. So this is all found on chromosome 11, and these are the various exons that are associated. And how the androgen receptor works is on what I want to point out to you is on the left side of this slide. This is what I sort of call the canonical pathway. And so we're going to go through this pretty quickly. So what tends to happen in normally functioning prostate cells and men is that testosterone really circulates. Most of it is bound by sex hormone binding globulin, but the functional activity of it is actually free testosterone. So what happens is that testosterone disassociates from sex hormone binding globulin it diffuses through the membrane of the prostate cell. Once inside the cytoplasm, it then encounters the androgen receptor. Now, the androgen receptor, when it's not locked into the ligand, it can be found with what we call a chaperone molecule, which is usually heat shock protein. Testosterone, once inside the cytoplasm, gets converted intracellularly by the enzyme 5-alpha reductase to dihydrotestosterone. Dihydrotestosterone is a much more powerful androgen. When it comes into association with the androgen receptor, you get dissociation of the heat shock protein, you get binding of the ligand to the ligand binding domain of the receptor. You then get this dimerization of the ligand receptor complex. What then happens is that you get nuclear translocation. Once inside the nucleus, the N-terminus then binds to DNA, which then starts the whole process of transcription and translation. That's how it works. And what do we get for that? Well, we get PSA production, we get cell growth, we get cell survival. Remember, it's a very important point, and we forget this sometimes, especially as we're treating advanced prostate cancer patients. PSA is a function of androgen binding. It is an androgen-driven event. But as we get into these pathways of castration resistance, except for, and as Dr. Pinthas talked about, except for the true neuroendocrine dedifferentiations in the small cells, which often lacked AR expression, a lot of the escape mechanisms still revolve around the androgen receptor. So that's why we have moved into this change in nomenclature of these patients being hormone resistant, androgen insensitive. I think, Dave had a very nice suggestion a couple years ago that these should be called endocrine resistant. So when you look at this, and this is a series of slides that actually I borrowed from Phil Kantoff, is that these are all the various targets that we could be potentially looking at on how to control this disease. Well, obviously, the first one is to do what we always do, which is look at circulating testosterone. So we can do that with LHRH analogs, castrations, surgical castration. And again, what that's going to do is drive down circulating testosterone. You can knock out the paracrine or intracrine production, which is basically at the adrenal gland. And again, we know that ketoconazole used to do that, and now we also know that abiraterone acetate has its effect there as well. You can actually degrade the androgen receptor, as well as blocking some of these chaperone molecules. You can obviously block the androgen receptor. And obviously the earlier ones were these first generation anti-androgens, including flutamide, bicalutamide, nilutamide. But then also we now have the second generation, which includes enzalutamide. Also what you're going to get is ARN-509, also now known as apalutamide. You can prevent AR nuclear translocation. And how do we do, so as if you heard the lunchtime talk, we know that enzalutamide can block nuclear translocation, but one of the great questions that Dan Petrolak has said is that, true or false, taxane chemotherapy has a role in the androgen receptor, and the answer is true, because we think that because of its microtubule inhibition, it can also block nuclear translocation. You can interfere with AR enablers, and again, these are some of these escape pathways. You can block coactivators, as well as you can block these downstream effectors, which again get into these whole areas of molecular drivers. So again, what's key here, what's common here, again, it's still the presence in the working of the androgen receptor. If you want to read a great article, this was published in the Journal of Clinical Oncology in May of 2013. This came out of the University of Michigan. This was Raoul Shanayan's group. Raoul basically is obviously one of the most talented guys when it looks at looking at molecular drivers for prostate cancer. And this is a very nice review article. And what he was able to do, he basically summarized looking at clinically relevant genomic alterations. And I'm not going to read all these, but this is what basically we're starting to talk about. TMPRSS2 transcription factors, obviously alterations in the androgen receptor, PTEN loss. We talked about aurora kinase and those types of things. And then these are some of the targets that you can go after. So again, this is a very nice article that I would encourage all of you to read to sort of get a baseline in terms of trying to understand these molecular drivers. And again, this is just a little bit of a different way of looking at it. And again, we're looking at obviously the androgen receptor, but then you can also look at basically the effect of tyrosine kinase receptors in all these alternative pathways, including PI3K, again, PTEN loss, and again, in green here are potentially all the potential drugs that we can use to alter these pathways. So again, what I'm trying to get you to understand here is that we're understanding more and more, and it's becoming more complex. Neil talked about today that what happens is that these cells they're going rogue, and they figure out a way to evade apoptosis. And so that's really the problem that we really have now, is that we have lots of cool agents. All of them are different mechanistically, but there's nothing to help us to guide these therapies. And we know that these cells with treatment pressure selection will actually undergo mutational changes. And one of the things that a lot of people are focusing on right now are these androgen receptor splice variants. This depicts just a few of them. Again, there's probably 40 or 50 of them out there, but a lot of attention has been towards this what we call this ARV7 splice variant. So again, this is where the understanding of the makeup of what the androgen receptor does becomes very, very important. If you don't understand the makeup of the androgen receptor, it's hard to kind of get your head around why ARV7 is so important. So basically, AR splice variants are associated with poor prognosis and treatment resistance. The translation of splice variants results in proteins with altered activity vis-a-vis the androgen receptor. So again, we know that in exons, so again, this is the full length, this is the wild type AR. Like we talked about, this area right here is the N-terminus, and it has nothing to do with ligand binding. This is sort of the DNA binding domain as well as the hinge region. This is all involved in transcription. Now, the C-terminus, this ligand binding domain, is coded for by exons 5 through 8. And so what happens, one of the mutations that happens is that you get this dropout of exons 4 through 8, which results in the loss of the ligand binding domain. So you would think that's a good thing, right? Can't bind dihydrotestosterone, you can't bind testosterone, nothing should happen. Well, the problem is what they have figured out is that the receptor stays active. It stays active. And what's the data to suggest that? So, many of you have seen this. Neil presented some of this today. This was basically the work done by Emmanuel Antonarakis at Johns Hopkins. This was written up in the New England Journal of Medicine. And so what this was a prospective study of M1 CRPC patients who were eligible for either treatment with abiraterone acetate or enzalutamide. And through the use of circulating tumor cells, looking at the transcript, they were able to identify who was ARV7 positive or negative. And so what I want you to do is go down to this bottom line first. So the patient treatment status, what was the prevalence? And this is an interesting number to remember. What's the prevalence of ARV7? So before any patients got either enzalutamide or abiraterone, we think the prevalence of ARV7 to have this mutation is about 12%. So obviously that's just due to a patient being on androgen deprivation therapy. And so what they did is that they measured baseline ARV7 using circulating tumor cells. And in the treatment group that was going to get abiraterone, they found 6 of 31 patients, about 20%, were ARV7 positive. And in the enzalutamide group, again, 31 patients, it was a little higher at 39%. So, so basically, in the ARV7 positive category, those were the numbers. And then what they did is that they started them on therapy and then looked at these various responses. And so remember, if you're ARV7 positive, manipulating the androgen axis, whether you put them on an androgen receptor blocker or you put them on an androgen synthesis inhibitor, it's not going to make any difference because it can't bind the ligand. So lo and behold, when they looked at their response rate, looking at drops in their PSA of greater than 50%, what they found in the abiraterone treatment group is that if you were ARV7 negative, so you still had the wild type ARV7 receptor, lo and behold, about 70% had a PSA drop of greater than 50%. The number was 0 if you were ARV7 positive. The overall survival, radiographic progression-free survival, 2.3 months in the ARV7 positive group, greater than 6 months in the negative group. Overall survival, better, obviously, in the ARV7 negative group. And the same pattern held true with the enzalutamide treatment group. Again, if you are ARV7 negative, the chances of you having a drop in PSA, which again would make sense, was over 50%. You had a longer RPFS, and the overall survival had not been reached. But again, when you look at the ARV7 positive group, numbers were markedly less. And then when you look at the patient treatment status, again, there was about a 12% prevalence at baseline. Post-enzalutamide, that went to about 25%, 50% for abiraterone, greater than 60% if you had both. These are the waterfall plots, and again, Neil had mentioned this today. You did have some outliers, but again, in blue are all these patients who are ARV7 negative, and for the most part, you had significant drops in your PSA. So that was the enza-treated group, and this is the abi-treated group. Again, the point here is that if you're V7 positive, and that's where it helps to understand the makeup of the androgen receptor, you're not going to bind ligand. It's not going to have an effect. The receptor stays active, and as Dan had mentioned earlier, you could make a case potentially of putting those patients. If you knew that up front, you would skip abi, you would skip enza, and potentially you could make a case for going right to a taxane. And again, this was the survival benefit, and again, this is for the enza group, the abi-treated group, and again, this held true. So that's just one mutational defect. That's just one resistance mechanism that these cells develop. The problem is, as we know, prostate cancer, it's a heterogeneous disease. There's heterogeneity. This concept of it starts here, and then every tumor cell enjoys the same characteristic, and then as it progresses, it maintains. That's just not the case. That's why we know, looking at these clones, there's areas of Gleason 3+3, but within the same tumor itself, you're going to have Gleason 4+4, you're going to have 3+4, you're going to have 4+3. At a molecular level, once these patients start to progress, the challenge is to try to figure out which mechanism, which driver is causing these to progress. Another mutation is a gain-of-function mutation in dihydrotestosterone synthesis in patients with CRPC. So remember, what we talked about is that dihydrotestosterone is formed from the conversion from testosterone to DHT by the enzyme 5-alpha reductase. And so what they found is this mutation in 3-BHSD1, which actually will produce dihydrotestosterone from variant precursors, not testosterone. So in other words, you are taking other ligands that's not testosterone and converting it to dihydrotestosterone. So again, it's another mutation. It's another way to drive the androgen receptor without altering testosterone production. You can also activate the glucocorticoid receptor, which confers resistance due to anti-androgens. And again, this was a study. These were patients on enzalutamide. And what they found, and this was actually out of bone marrow biopsies, these patients got enzalutamide, they continued to get it, and then what happens is that they actually tested, and what they found is that you had activation of the glucocorticoid receptor. So even though you were blocking the AR, it was escaping, the cells were escaping by activation of a glucocorticoid receptor. So the bottom line is that this is a challenge. And again, we have to be very aware of all these mutations. This was a really great, another great article published in Cell back in 2015. This is basically the Stand Up to Cancer group, funded heavily by Prostate Cancer Foundation. Robinson and Charles Sawyers and these guys. And again, this is a wonderful article that I think everybody should read. So I'm just going to wrap up. And so these are the challenges, all these different drugs. How do we know who to treat? How do we know which drugs? David has convened another working group, this, Radar 2, trying to come up with some semblance, some order on how we need to think about this. And this becomes very daunting. So, here's the prostate cell. We have to deal with the bone microenvironment. We can manipulate the immune system, which I'll talk about later. You can also have angiogenesis. So all these things come into play. And again, they're probably all in play. And we have to figure out a better way. Liquid biopsy, CTCs, cell-free DNA, tumor DNA, microRNA, all the things that we talk about in terms of monitoring. What's the best way to sort of dictate how we manage these patients? So I was telling, I think, Jerry Andriel, so this is actually a really good book. I would suggest you read it. This is Mukherjee's book. This is his follow-up. He's a medical oncologist at Columbia. He wrote Emperor of All Maladies in 2011, which won the Pulitzer Prize. And this book actually is called The Gene. I think it came out the middle of last year. And he really talks about this whole concept of genomics, transcriptomics, proteomics, epigenetics. And really what drove him to write this book was his family history of schizophrenia. So he was trying to figure out, is there some sort of genetic profiling? So again, I would strongly encourage you to read this. So in conclusion, the androgen receptor continues to be a major driver in the growth and survival of prostate cancer cells, even in the CRPC patient. As urologists, we really need to understand the nuances of resistance mechanisms and genomic alterations. And despite all the recent advances, there remains multiple challenges and opportunities for researchers to better understand the disease and possible development of novel targeted agents. Thanks so much.